Morning everyone. My name is Latika Pai. For those of you who have not engaged with, I'm assuming I have with everyone. I lead, Project Amplify for Microsoft globally, and one thing we realized is that we were spending a lot of time bringing external speakers, to our various webinars, which are, extremely useful, but at the same time, not necessarily creating an opportunity, which, typically, ideally, we if we had a boot camp, which was in person, everybody got to know each other, and we actually, landed up connecting and meeting with each other. We would get to know what other founders are doing. So we're kickstarting a founder series where it really is for to get 3 to 4 founders to speak about what they're doing, and for other founders here to get to know what the work, to see if there is a way y'all can collaborate with each other, and then understand what the benefits are as a result of this collaboration. The format is going to be where I'll request each one of the founders to talk about what their startup does. It's going to be interactive, so for all of the other founders who will join us today, I request you all to, maybe use the Teams functionality to put your hand up. I don't want to wait till the end for questions because, I don't know whether the others find this, but I forget what my question is if I don't ask right away. So you can either put it in the chat or put your hands up, and then we'll finish with each founder and go to the next founder. We probably should take about 60 minutes, 70 minutes based on the number of questions that we have. And when you ask your questions, please feel free to turn on your cameras and ask the questions. Again, this is more of a closed door event, and so please, again, the the intent of this workshop is for founders to get to know each other. So I would encourage you all to turn your cameras on when you ask your questions, so everybody gets to know you. So thank you. So we have with us 3 founders, and what's very exciting is that we've got them from 3 different parts of the world. We have Rahul, the founder of Docturnal, based out of Hyderabad. We have Sara and Ifat, who is a co-founder of Sehat Kahani, based out of Karachi, and we have Sylvana and Sinha, based out of Dhaka. So this is very exciting. That we are actually engaging with 3 different startups from 3 different parts of the world doing some phenomenal work. Rahul, over to you. If you could please, bring, tell all the others on the call today as to what Docturnal does, your journey so far. That would be great. If you have some slides that you would like to share, please do so. Rahul, you're on mute.
Rahul, you're mute.
And so Rahul, did we lose Rahul? Rahul.
Yeah. Okay. So, hello everyone. My name is Rahul Pathri. I am the founder for Docturnal, and what we primarily do is non-invasive point of care screening for lung ailments, leveraging signal processing and needless to say, machine learning and artificial intelligence, and that's primarily what we do. We started off in 2016, and our flagship product is titled as Timber, which is like focusing on pulmonary tuberculosis. And needless to say, over a period of time, we accumulated data related to other lung-based ailments. As you can see on my screen, I've already spoken about the AI ML point of care, non-invasive in nature, where we leverage acoustic epidemiology, wherein we collect the human cough and a certain set of demographic and clinical variables and provide explainable and interpretable results for the physician and other stakeholders. Yes, we were focused on pulmonary tuberculosis. Now, with the pandemic hitting, COVID-19 has been our focus. And then these are the infectious diseases side of things, and in the non-infectious disease space, it's COPD and asthma. However, with COVID-19, spiking up and down, there's a lot of concern amongst subjects who have a certain symptom. Now it could be COVID, it may not be COVID. So now we have differential diagnosis in the form of identifying influenza-like illness, severe acute respiratory illness, and so on. So a quick, when I say non-invasive, we collect the human cough on a sophisticated third-party microphone array, and uh, and also the demographic and clinical variables as a part of the mobile phone. And all of the processing happens on the cloud, and we send the results on a portal, a secure portal for the physician and the decision makers. Because it's a screening test, we try to integrate it with other unique identifiers in the public healthcare systems. Primarily, NICSHE ID is what is being used for uh, tuberculosis identified patients in the public health systems in India. So that's what it is. And now we are offering bidirectional screening of both pulmonary tuberculosis and COVID-19 in one shot, one single cough. We record and we try to determine or leverage machine learning solutions to predict the propensity of a subject's cough signature revolving around COVID-19 or pulmonary tuberculosis or other differential diagnosis. I'll skip this clinical trial part, but a quick snapshot of what happens on the field, contextually relating it with SDG 3.3 and 3.4 and 3.2 goals. Pediatrics is something that we are working, but yes, that's in the pipeline. But adult pulmonary tuberculosis and COVID-19 and other non-communicable diseases like COPD and asthma is what we do. I'll pause here, Latika, and that's what we do, and that's a quick introductory description of what Docturnal does.
Thank you, Rahul. Do we have any questions from anyone in the audience for Rahul? Okay, while people are trying to come up with questions, Rahul, my question for you is, what do you think are the challenges to scale what Docturnal is doing today?
Because our focus is on public health problems, not necessarily. There's a lot of discussions going on with
Rahul, do you
respect
want
to.
to stop presenting so that
Okay. While I fix this, there's a slight problem here, but yeah. Okay, so the biggest challenge I see is, since we are focused on public health, and with COVID, with the COVID hitting 2020, there's a lot of emphasis on clinical validity, research publications, which is needless to say. However, now everybody is on their toes in the public health systems. It's not prior to 2020, things were a little bit different. People were enticed and amazed about the whole AI solution, but now there's a lot of emphasis on the third-party clinical validation. I wouldn't call it as a challenge; I would call it as an opportunity. But the real challenge comes in the form of public health systems acceptance and kind of rolling the ball forward. That is one. And number two is, we do talk a lot about public-private partnerships. And that is something that would really open the doors, because in public health system, what I've seen practically is there's so much of excitement when we predict a pediatric case or an adult case, and there's a lot of signal processing and a lot of machine learning that goes behind. We are excited, but the stakeholders are not necessarily. I'm not of the opinion that we need to educate them, but yes, there are certain buzzwords around acoustic epidemiology and AI and ML, but probably we want to see them as partners with respect to our whole AI ML approach. Number one, this is too much of a trivia, but the other challenges would be when people cough now, we are infection aware. People have to cough with a surgical mask, and then we need partnerships with other biosafety methods where we have a foolproof mechanism that in a public health scenario we are not infecting other folks. So these are a few challenges I would say are in front of us. But by and large, I definitely see COVID-19 as a humongous opportunity moving forward for Docturnal.
Is this technology that you have developed for Docturnal something that is unique to India, or are there others who have developed it and using it successfully in other parts of the world?
Prior to COVID, very few. Just to name a few, there's a ResApp from Australia. But post-COVID, yes, there's different universities working who have developed COVID solutions on mobile phones. The mobile phones, like Stanford has done something on COVID, which did not see light at the end of the tunnel. But then MIT has done, and they claim an accuracy of 98% sensitivity. And one of the challenge I did not emphasize on is on the field there are different devices and mobile phones that come with the brand new phones, with the USB-C type converters and so on and so forth. There's a lot of variance. So while we stick to a consistent third-party microphone array, there is a lot of the real challenge is people actually ask us, the stakeholders could be public health specialists, physicians, and even subjects themselves. Can I do this on a mobile phone? Yes, you can do it, but the accuracy dips by 70%. So that's something that I forgot to mention as one of the biggest challenges. But yes, long story short, MIT, Stanford, and several other players from India are working on it, on acoustic epidemiology, not only for infectious diseases, but yes, Parkinson's disease, voice-based solutions for Alzheimer's and Parkinson's and so on.
Great, thank you. Any other questions, or we can come back to it them in the end. Thanks, Rahul. Sara, over to you. If you would like to do a brief description of what Sehat Kahani does, that would be great.
Sure, thank you, Latika. I'll just share my slides and get started.
So while Sarah's getting the slides, again to the audience, this is not a one-way. The whole purpose of the Founder Series is to get to know each other, ask questions. I think, this is an opportunity for you to know more.
Can you see my slides?
Yeah, good. We're good to go.
Okay, perfect. So as Latika was saying, I'm happy to answer any questions from other founders after the presentation. So I'm Sara. I'm a medical doctor by profession. I created Sehat Kahani with my co-founder. Her name is Ifat. And Sehat Kahani means story of health in Urdu for some people who are not familiar with the language. And our mission is to enable healthcare for all in Pakistan using the power of technology and a resource of untapped female doctors. And why I say that is important in Pakistan, because Pakistan has two major healthcare scenarios. The first healthcare challenge that exists in the country is related to the amount of missing doctors that we have. So Pakistan has around 200,000 doctors for 20 million people, which means there's one doctor for 1,000 people. However, in our country, because medicine is considered to be a very noble profession, a lot of females go into the profession. So 63% of our total doctor force is female. But while people consider the profession to be very noble, they don't consider working as very noble, and there's still a taboo of women working in Pakistan. So a lot of female doctors complete their degree but never actually practice. So around 85,000 female doctors are out of the workforce today having a degree in their hands, whether they did not work themselves or they were not allowed to work after marriage or having children, because again, the idea of working women in Pakistan leaving their children behind and their house behind is still considered taboo. What it does in the fifth largest population of the world, that is my country, is that we are left with one doctor for 1,700 people, which is way below the minimum WHO standard. Also, 80% of our doctors work in urban areas, leaving a very small doctor force to be present in the rural areas. What it does for the patients in our country is that it strips half of our population to get access to quality healthcare in their lifetime. So 100 million people in Pakistan never see a doctor in their lifetime, and that ranks Pakistan 154th out of 195 countries in terms of accessibility to healthcare. I've just stated some maternal and child health indicators here, which are very important. The Pakistan is the second worst country for newborns to be born. A woman dies every 37th minute in pregnancy. So we have very sad indicators of maternal and child health care. 40% of children in Pakistan are stunted, and the fertility rate is very high. Why I've listed these indicators is that all these are solvable issues if there's quality healthcare available in the communities. So what Sehat Kahani does, very briefly, is we connect this network of female doctors from their homes to patients who need healthcare using a telemedicine solution. So we empower all the doctors working within their cultural boundary of not leaving their home and ultimately connect them to places where they can provide healthcare using a chat, audio, and video-based solution. We work in low-income areas through a chain of clinics. So we create clinics in low-income communities where a nurse is sitting, and when the patient walks in, the nurse connects the patient to the online doctor. These are generally communities where female doctors are not available. However, internet is there, and there is a nurse who can guide the patient to connect to a doctor after she's trained for the software. Along with this, for urban populations, because we realize that healthcare is not just a problem for low income in the country, it's also a problem for everyone else when it comes to quality, affordability, and accessibility to doctors. So while we are expanding this chain of clinics in low income communities, we also launched an app just before COVID in Pakistan, which does the same minus the nurse. So for urban populations where smartphones are present, a patient can download the application and connect to an available female doctor in less than 60 seconds. And that's the USP that Sehat Kahani provides as the only telemedicine company in Pakistan, that we connect an available female doctor to a patient in less than a minute. And we do realize that not everyone has smartphones in the country. So we also have a solution through a mobile phone, which is a helpline that also connects a patient to a doctor in emergency situations. So today, Sehat Kahani has around 35 clinics across Pakistan in low-income communities. We're the largest private telemedicine chain in the country. All of these enable nurses to connect patients to online female doctors for GP specialists and mental wellness care. Our application is used by corporates as well as consumers. Our application is used by 253 corporates today actively, and the overall base that we have now secured is around 753 corporates, and we're unlocking them as we go. Our retail app is thus far used by 300,000 patients, according to what we've done in the last 1.5 years. Overall, we've provided over 570,000 consultations till date, and overall in our clinics, corporate and consumer portfolio, we cover around 7.2 million lives. I think Sehat Kahani's purpose is to make sure that the quality healthcare resource that we are creating year after year does not go into waste, and we reintegrate them back into the workforce, making sure that all of these female doctors have something to do from their houses, and also solve a big healthcare challenge for the country. So we envision to bring back 50,000 female doctors back into the workforce. Right now, the network is around 6,000 female doctors. We also want 10 million patients in Pakistan to have quality and affordable healthcare using our solution. And in that process, we want to make our solution very efficient, user-friendly, and at the same time affordable, so that patients from all walk of life can access the solution and use it easily as well. We also believe that this is a problem which is not just limited to Pakistan, but other areas where there is a high population of underserved patients, especially in refugee situations, where our female doctors can get help to these patients as well, using our mobile application. So we are looking at an opportunity to expand outside Pakistan in Bangladesh, MENA, and Saudi Arabian regions. So I'll stop here, and I'm happy to answer any questions that you may have.
Thank you, Sara. Again, let me ask questions on behalf of everyone else until the others have. I met Sara and Isat when I was in Pakistan a couple of years ago, and the work that they've been doing is just fantastic. More importantly, the way they have managed to scale in the past 2 years is just fantastic. So congratulations, and it's not necessarily the easiest country to do business in. Any emerging market is always a challenge. So Sarah, you were dealing with multiple challenges. One is bringing the female, doctor workforce back into play. So there were a lot of cultural nuances that you needed to take care of. You also said Kahani was dealing with the fact that you needed people to understand technology and technology adoption. That itself is a challenge. Okay. Third, in terms of, now 80% or more of your doctors are female, but you do have a huge male base of patients, right? So these are all three in and of itself huge problems to tackle. So let's go one by one to let everybody know. First, how did you manage to get the female doctors to be a part of Sehat and get for them to get permissions from their family to come and join you all, to be a part of your team?
I think the biggest problem that any female, not just female doctors, so we specifically work for female doctors because they make a majority of a workforce, which they don't in other sectors in the country, so it impacts them more. But generally, females have problems getting out of the house in Pakistan, and they have a cultural boundary to stay inside, to cook, clean, and take care of their children, and not leave them on a nanny, especially if they live in nuclear families. So when we provide them this opportunity, we tell them three things. We tell them that they can work whenever they want. They can be the deciders of where they want to work from, and they can let us know if they can't work on a certain day. So it's a very flexible network where there's a lot of cooperation from the entire community. So a doctor tells us that, okay, I can work 9 to 1 because that is the time my children go to school. Or there are doctors who are based outside Pakistan, the US, who work in the night hours because that is when their children go to sleep or they don't have to do other chores. So they can decide their time. That's what gives them the flexibility. I think because they're working from a section of their home where their children can be in the next room, they can be cooking and cleaning at the same time. Generally, people appreciate this more rather than them leaving and going somewhere to work, which is a cultural problem in the country. So we didn't face an issue from families not letting their wives or their daughter-in-laws or their daughters work. However, we do face challenges of maybe putting their profiles on social media, of maybe telling their story a lot more, which we come by with effective digital media planning. So it was relatively easy to build that network of female doctors, but it was difficult to understand what challenges they go through. So for example, a sports day is very important problem for us to take care of in the country because we know that a mother needs to go to their child's sports day and be with the child in case of emergency. So these we take care of these in our leave policies, that you can take a short leave in a day if you want to do. I think the second part of it was convincing a patient base that this is a doctor that can help with your issues, and it doesn't matter if it's a female or a male doctor. I think that we overcame with a lot of work on our quality assurance, patient management, history taking skills, communication skills with the doctor, and we developed this over time. So now we have an online learning management system which every doctor has to take before they join Sehat Kahani formally. And while it has revision of medical protocols, it also focuses a lot on communication, history taking skills, and empathy. Because what we realize that in Pakistan, a doctor-patient communication is around 180 seconds per consultation, while on Sehat Kahani, it's around 18 minutes. And that's where that difference comes, because when the patient and doctor talk to each other, the doctor asks, okay, how are you? How's your family? What are you going through? I think that really made a difference. And we took these learnings from our low-income clinics and we put this in the application. Also, a lot of times when patients use our application, they just want that instant connection with the doctor. So they're just happy that the doctor is available in the 60 seconds. At that time, is the doctor male, female, just kind of wipes out from their scenario, because at that time they need help. Those were the things that we did to overcome this gender bias that may arise for consultations. One thing that we did was we did hire a lot of male doctors for specialities for which we couldn't find a female doctor, or there were some cultural issues. So for example, sexology, urogenitology, psychology are problems in which a male patient would not be comfortable talking to a female doctor. So for that, we did hire male doctors in the mix just to make the patients and doctor comfortable. But now I think because we have the clinics and the app, it's a very flexible system. The doctor actually has a toggle. They can switch their time on and off. And we have enough doctors in the network to meet the patient demand. So it is working out well at this moment.
Great, thank you. Nico, why don't you turn your camera on and ask the question that you have, if you have, or just maybe Nico?
Yeah, hello.
Yeah.
Yeah, I just wondering, you mentioned about the rural area, right? Because maybe some of us, the founders, is also facing the same issue, because the people is not only doesn't understand yet about our product, but is not too familiar with the technology. For example, the internet. They only use the phone for WhatsApp, for the shopping, to the e-commerce side, and how you overcome with that kind of these people to understand how your product works and how use the phone to maximize your user, for example?
Yeah, so I think that's a great question, Nico. So what we did was that we in Pakistan, I do realize that although we have half of our population uses smartphone, half of our population is not educated. So they use applications where there is visualization but no writing, no reading. Which is generally WhatsApp or TikTok or other where they post videos. So we always had this hybrid solution in which in low income areas we run a chain of clinics. Now these are physical clinic. There's a physical nurse sitting inside the clinic, and we train the nurse on the Sehat Kahani app. So when the patient comes in, the patient does not use the software themselves. They generally don't have a smartphone also. The nurse makes the connection between the doctor and the patient, and this is what we call the assistive telemedicine module within Sehat Kahani. So nurse takes the history, she puts that in, and then the doctor starts consulting with the patient, and then nurse does the examination or any tests or any procedures that need to be done after the consultation. So that nurse is very important, because this is that educated person in the community that is our eyes and ears and our champion as well. And we usually hire nurses who have been working in the same community for the last 8 years. So they have a rapport built already in the community. It's not someone new and alien to the community members. So I think this is something that has really worked in our model for low-income community members. And of course, for urban users, then they can use the app themselves. But in low-income areas, we market our clinics because we understand that patients need to trust someone to make them comfortable with the software that they're using. And for us, this has always been the nurse that does that for us.
I see. So you make it kind of a hybrid approach for
Yes.
this kind of users, right?
Yes, exactly. Yes.
Amazing. Right. Thank you, Sara.
Thank you, Nico. Thank you.
Rahul, you had a question for Sara?
Yeah, Latika, thank you so much. Sara, amazing work that you are doing. I am part of Latika's team in India. So I just wanted to understand, I'm sure, the journey that you have embarked on may not, I mean, cannot escape the challenges that are coming day in, day out. And one of them which I would like to know is on the technology side. So any critical challenge which you want to highlight, and if you have overcome it or if you're trying to do it, that will be a good learning for the people here. Just if you could throw some light on that.
And also
I think,
maybe you could mention the support that Microsoft has
yeah,
given you.
yeah, yeah.
So that's something others could also leverage.
Of course, of course. So I think because I'm a non-technical co-founder, I'm a medical doctor, and if you are aware of the India-Pakistan medical doctors, you'll realize that they're far away from technology when they're being trained. So we got our application initially made by one of the best software house in the company, and then they invested in us. So then we moved the software in-house, and now we have a team of 11 people that handles it, does any upgradations. I think the biggest challenge or the learning that we have is how to make the application very user friendly, because it's the simplicity that attracts people in our application and not the complexity of it. So when the patient comes to our app, they on the second screen they get the list of the doctors and they have to just click on one button to enter a consultation with a doctor. And that can be a chat, audio, video consultation depending upon the internet bandwidth. I think correcting this part was extremely important, because in that 60 second when the patient is waiting for the consultation, so we are talking and 60 seconds will pass very quickly, but when a patient is looking at the screen, those 60 seconds seem like 2 or 3 minutes. So just making sure that they're engaged and the doctor connects in the 60 seconds. So we really, really meticulously measure the amount of missed calls we're getting on the application. And when we started, it was 60% in 2019. Now we brought it down to 18%, which is a huge jump. So almost 82% of our doctors pick up the call in less than 60 seconds, which is important. Then how do you make sure you gather their feedback? So again, how do you send the prescription? How do you make sure that the medicine is being delivered if they've ordered for it? So making sure that that user journey is just really, really straightforward for the patient and convenient is a challenge that we solve on a day-to-day basis. So up till now, every day when I see that missed call number going up and down, my heart gives a beat, because I understand the value that we're providing when we connect them to the doctor. So I think that was a challenging part and still something that we're overcoming. But I think how Microsoft came in the picture, and of course there's how we store our data, how we maintain it, how we maintain its data security. That's something that we have really taken Microsoft help from mirroring our data to securing it in separate containers, to making sure that it's very secure, and also it's very it's encrypted, because data security and identifiability is a big concern when it comes to healthcare applications. So in terms of data security and protection, I think Microsoft tools has been amazing. But one thing that has really made my life easy as a founder is using the Microsoft BI tool. We use that extensively for all our dashboardings on our corporate app, on our consumer app, on our clinical application. We generate day-to-day reports for all our corporates for them to see. We have a live dashboard that anyone can view. And I think that has really made difference when it comes to our corporate and clinical solution, because everyone can just see live how many consultations are happening geographically, gender diversification, top 5 diseases. So I think the Microsoft Power BI tools are very important. Now what we're figuring out is how, and we're working with Microsoft experts on something very interesting. So we're actually working, because the doctors, when they're writing notes, they write in a very non-formal language. So how do you take up that non-formal language from their doctor notes and split it into identifiable data so that they can be stored against the history of every patient and can be used for research or trend analysis later, something that we're discovering with the Microsoft experts that we're working with under the program. So I think that has been, but data visualization and dashboarding has made an absolute difference in our application, which is something that we are continue using as well.
Great. Thanks, Sarah. Sylvana, over to you.
Great, thank you so much. It's wonderful to be here and really interesting to hear what the others are working on. So I am the founder of Brava Health in Bangladesh. We're the fastest growing consumer healthcare brand in the country. It's really an integrated outpatient care model. But just to set the stage for a second, I'll share kind of the healthcare system in Bangladesh. And it's really interesting to hear from the others in particular on the tech solutions that that you guys have introduced. But when I started out, I'm actually a lawyer by training. I came to this really from the perspective of a patient, and was really curious to see that there was tremendous progress that had happened in Bangladesh across my lifetime. And I was born and raised in the United States, but I'd visited Bangladesh frequently to visit family throughout my life. And yet it really appeared that the health sector was still challenged. There's huge variations in quality across the board. The average amount of time doctors are spending with patients is 48 seconds. There's really variable quality. There are more people dying due to lack of access to quality care than lack of access alone. There's only one internationally accredited lab. 10 to 15% of drugs in the market are counterfeit. And all of this really led me to believe at the time that I started the company, a lot of people were really encouraging me to build Uber of at that time, around 2014, 2015. Everyone was obsessed with Uber of things. And I realized, though, that the Uber of model could only go so far when underlying infrastructure didn't exist. And that is the challenge that we face in Bangladesh, is that the underlying infrastructure and the quality of care really is not present. And so what we've built is what we like to call a brick and click model, which combines infrastructure with technology meaningfully. And so we offer the full range of high quality in-clinic and remote and virtual services. And we own the entire supply chain on the front and back ends of that. So on the left side of the screen there, you can see a photograph of our flagship center in downtown Dhaka, which is the capital city of Bangladesh, a population of 30 million people. In the clinic, you can access consultations, and that includes consultations with family doctors, women's health, pediatrics, dentistry, ophthalmology, as well as advanced specialties like cardiology, gastroenterology, orthopedics. And we do outpatient procedures in all of the specialties as well. We have endoscopy suite, dental procedures, dermatological procedures, cardiac outpatient procedures. Full range of imaging services in-house as well as in-house labs. We have the 6 in-house labs, including the first molecular cancer diagnostics PCR lab in the country, which, as you can imagine, is currently engaged in COVID testing, as well as in-house pharmacy. And everything has been established according to international standards and quality. And so our doctors are practicing protocolized medicine consistent with the NICE guidelines from the UK. The lab is set up according to the standards of the College of American Pathology. The pharmacy only sources directly from manufacturers to eliminate the risk of counterfeit drugs, which is such a big challenge in this market. And then everything is embedded in and layered in technology. So we brought Bangladesh's first fully integrated hospital information system, which features the first patient app in the country, which we launched in our first year of operation. So we started serving patients in 2018. Initially, the patient app was really focused on medical records and appointment bookings, which, as many of you in the audience will know, is in and of itself quite novel for our markets because most patients are carrying their medical records around in bags. So with our app, all of your records are in one place from Brava. And if you bring us the kind of bag of records from your life outside of Brava, we'll scan and store it for you, which really promotes the continuity of care, both for the patient and for the provider. But it also allows, there's also a really massive data opportunity for us in terms of the data that we're collecting. In addition, when COVID hit, we rolled out a number of other digital products. We rolled out telemedicine in March of 2020. We were the first private provider to partner with the government on its free telemedicine hotline, actually. We volunteered our services to that. We rolled out e-pharmacy in May of 2020, and we've been building virtual primary care and remote chronic care management tools on top of that as well. And so really the idea is we are a one-stop shop for all of your outpatient needs, whether you need them at home or in clinic. We've been growing very quickly. We have 3x our growth every year since launch. We've served 250,000 patients, and we have a corporate network of more than 600 clients that includes insurers, and so a network of 5 million through that. So the idea and vision of the brand is really to build out the hub and spoke network, as well as to build out the technology piece. And we're in the process of building a patient super app where all of our digital products are available in one platform, because right now, because we rolled them out quickly during COVID, some of them are standalone solutions. And so in the next 4 months or so, we'll be rolling out the new version of the patient app, which we're very excited about. So, this brick and click concept has really picked up in more advanced economies such as the United States and China. So we're really excited to bring this to an emerging market and believe that it can actually be scaled across emerging markets. So I'll just pause there so that we can spend some more time on the discussion, but that's broadly our model.
Thank you, Sylvana. I can see, Sehat, Kahani, and Praava. Lot of interesting and complementary work that you all are doing. Sara, I see you have a question. Go ahead and.
I apologize. I know it's for the other founders, but obviously.
No, you are a founder, so it's
yes,
very.
It's extremely exciting, Sylvana. Thank you so much for sharing. I think it's great to know that you're doing all this. Super app is something that definitely is needed. I had a question on e-pharmacy because the challenge that we faced in Pakistan is that 90% of our pharmacies are private pharmacies, non-regulated. And whenever we start building the e-pharmacy model for Pakistan, specifically focusing on the bigger 3 or 4 cities, because we're a larger company in terms of geographical area, the cost of operations goes high when you account for warehousing, picking, packing, delivering, and ultimately reaching to the customer, which doesn't happen in 4 to 6 hours, which is generally when the medicine is needed. So it's not like e-com that the parcel can come 2 days or 3 days later. How do you manage e-pharmacy? Because that's a challenge that I have been facing, building the e-pharmacy model along with Sehat Kahani services.
Yeah, no, it's difficult. I mean, I think it was made easier for us because we already had an in-house pharmacy. We were already operating our own physical pharmacy. And so just adding the e-pharma layer onto that. And we're actually focused on the Dhaka city right now. So we haven't gone outside of Dhaka. So we don't face the same issue that you do with transport into other markets. But I will say, I mean, I think the economics of e-pharmacy are difficult, right? I don't know what the regulations are in Pakistan, but in Bangladesh, the government sets the MRP, right? And so the margins are slim. You make a lot more on the non-pharmaceutical products than on the pharmaceutical products. But for us, it really is more about providing an end-to-end solution for the patients and to be able to, really be that one-stop shop. And so sometimes we're actually acquiring new patients through the e-pharma channel and then converting them up into other channels, which are more profitable parts of the business.
Sure. Thank you. Yeah, it's the same in Pakistan. So the margins are around 15% because the government sets the MRP.
Right.
So a couple of points, I think, for both Sylvana and Sara for Sehat Kahani, right? If we have the same challenges in India about the pricing of medicines. However, if you look at Farm Easy, spelled PHARM Easy, and MedLife that Farm Easy just bought out, it is now a unicorn. Okay, so what they did was really get to delivery of just their focus was not a 360 like what you and Sehat Kahani and Praava are doing. Theirs was just providing a way for online delivery of medicines. So definitely that is a space you want to figure out how to work with. Maybe find one distributor, etc., that you can work with who's willing to start a pilot with you. Partner with you have.
So we source directly from manufacturers, right?
Exactly.
And that helps our margins, but also it helps us to maintain the quality of the supply chain, because a lot of the distributors are not really trustworthy, unfortunately.
Correct. So that's another opportunity. You can also partner with delivery partners. I know Darevudu is one of the startups I had met in Pakistan coming out of Peshawar, if I'm not mistaken. There is what is Munir's the Uber Bike. So you have Bike, that's out there. So if you were to create a partnership with them, while you have maybe follow the Praava model, which is to say we will invest in getting the license to run one pharmacy, and then use technology, and it doesn't matter whether you have one or you're using technology for delivery. I think that may just land up becoming a very, very robust services offering. And I like Sylvana's point that the ones who came to your pharmacy turn out to be patients too.
Yeah.
So that 360 technology is the best way to go, right? If you know if you know what your diagnosis is, you know what the doctors have given as a prescription, and it's all in one place. I think that's lands up becoming a very powerful tool to have as a super app, and patients having all the information in one place.
Right. Yeah, true.
Rahul, you had a question?
Yes, Sylvana, this is more from the context of an early stage startup. So,
Mhm.
for now, take me as someone who is starting off, and many startups aspire to build a super app, and many of them falter during the journey because they are doing too many things at one time, and it doesn't lead to making an efficient um, technology model as well as a business model. So could you share some learnings on what should startups take care when they are either aspiring to build a super app, or if they should not be doing it, what is the best approach? Some thoughts
Sure.
on those lines. Thank you.
Sure. I think the biggest challenge for all founders is focus. It continues to be a challenge for me. I think, especially when the market opportunity is so huge for us in healthcare in Bangladesh, right? I mean, I think the healthcare CAGR in Bangladesh is 11%. Per capita healthcare spending is going to 5x in the next 20 years, right? And so it's almost every other day that either a patient or one of my own employees comes and says, "Why don't we do this? Why don't we do this?" Right? And I think that it's your job as the founder, it's our job as founders to keep the company focused. And so I will say, I mentioned that we brought Bangladesh's first fully integrated hospital information system. The first HIS that we brought was not our own product. We didn't build it from scratch. We licensed it because we took so many other risks. We have real estate, right? Like we were doing so many things. So I said, I'm not going to take the risk of building software on day one. And so we didn't, right? And even with the patient super app, right, we've rolled out the digital products in silos to test them out before trying to pull them all together into the super app. So this is just my perspective, and Latika and others might have other perspectives, but I would say to start out on day one saying you're going to build a super app, you may have that in your mind, but I would really focus on taking it one step at a time. I hope
So
that's helpful.
no, that's definitely good inputs. Sylvana, what do you see as the biggest challenge in terms of scaling? I know that funding is always a big challenge for everyone, but where,
Yeah.
yeah.
Well, yeah, I mean, funding is for sure our biggest challenge to scale. I mean, there's no doubt in my mind. When I started the company and people asked me that question, when I had a business plan and a financial model, I said it was human capital. And I do believe human capital is a big challenge for us in healthcare in our markets. But what I've learned in Bangladesh, unfortunately, the Bangladesh, Bangladesh still somehow falls between the cracks of Southeast Asia and India and Pakistan, and still isn't attracting the levels of venture investment that it should for the size of the economy and for the opportunities. And so I think, I've proven the economics of my business. We achieved cash flow positive by the end of last year, but fundraising continues to be as challenging as it ever was. So I can't underestimate that challenge more, but I think that the lack of access to capital has given us discipline and forced us to get to the point that we were cash flow, right? I think there are good things about that. It really, we learned to be extraordinarily capital efficient. The human capital challenge, of course, is also there as number two. And I think as Sara mentioned, similarly in Bangladesh, 75% of the medical professionals are living in Dhaka, the capital, not even in the other urban settings, in one city, right? And so as we look to scale this outside of Dhaka, it becomes more and more challenging, I think, to attract talent. But within Dhaka, we've been very lucky to attract some really top talent. And I think there are a lot of doctors who are really frustrated with the way care is being delivered and just with the system as it is. And so they're very excited to be part of a new model. They're excited to have access to the latest technologies and to get training opportunities and a lot of the things that we're able to offer them. So it's been easier than expected, but as we scale, it will become more and more challenging.
Rahul?
Yes, Sylvana, just taking the question ahead on fundraising, and I'm asking a very cliched question of, as a female founder, what challenges do you face when it comes to going through that process of raising funds? What kind of perspectives you have heard from the investors, and how have you overcome as a founder to, fight that biasness? And I mean, just some experiences on that would help
Sure.
other folks to be more aware of this.
Sure. No, it's a good question. And I think there's a lot more awareness around it than there was. But I have to say, I don't like to focus on the female founder thing because it's really hard to quantify the extent to which it affects my fundraising experience. Because I'm not sitting in the room when men are pitching. I don't know what their experience is. I only know what my experience is. But I will say, one of my male investors sat in on one of my meetings with another investor, and he's an entrepreneur himself, and he came out of that really shocked. He said, they asked you crazy tough questions. He's like, I've never seen that level of detail asked of a founder before. And I had the answers, fortunately. And I think the answer is you have to have all the answers. And I actually think if everybody's going to be harder on us as female founders, I think that's a good thing. It makes us better founders, right? Like, we have to know our stuff better than anybody else. And I try to really take it as a positive. But, sometimes when things don't make any sense, you do wonder if the reason that something is happening is the gender thing. But you just never know what's happening inside of investment teams or inside of, other people's minds. But I think that, it's important. And most women who choose to be entrepreneurs have already accomplished other things in their lives and recognize that it's challenging in this world for women to do anything, right? And so I think that entrepreneurship is no different, unfortunately. But hopefully it's starting to change because people like you are asking the question and people are talking about it a lot more. Sara, I don't know if you want to add anything to that from your perspective.
So I think I recently sat because I've raised a seed, I've raised a pre-series A, and I did face a longer time to complete that round. And I had a lot of rejections that came later in the conversation. But as Sylvana said, you never know why that's happening. So I don't want to place it on, the deal didn't happen because I was a female founder. However, I sat with an investor friend who became our CFO and was previously an investor, and I asked him, what happens after we pitch? And he said that most of the time, because there's so many men in the room having the conversation, the question does come up because Pakistan itself is a risky economy to invest in. We don't have policies and procedures that help the investors from outside coming in. Now, on top of that, you're placing the risk on the founder because the business is really small and most of it is projections and dreams that a founder builds around it. Now, what he told me is the risk comes in when that founder is female, because then you also have to ask yourself, will she continue? Because we have families, there are roles that the cultural economics decides for a woman in our country. So they just ask themselves this question, okay, is investing in this male founder less riskier or investing in this female founder more riskier? And in that question, always a female founder suffers because, there's always a point where their propensity to give up a business can be more, according to popular opinion, as compared to a male founder who doesn't have to take care of the house, doesn't have to take care of the children that much, doesn't have to contribute in day-to-day working. So that is how it becomes difficult for investors to place their bets on female founders. I have once been questioned by an investor in front of my husband that your wife is an entrepreneur, she's raising a round. However, if she had to choose between you or her business at one point of day in her life, what would she do? And at that time, I'm not a person who doesn't have answers. As Sylvana said, I always over prepare. But at that time, I could not answer. And he got what he wanted. So it does get tough. But again, when your options are thin, then you fight for whatever you get and you fight harder. And you don't have a lot of options to fail. And ultimately, you find people in that mix of investors. Ultimately, you find the investor for him, the female founder is not a problem. And is an opportunity. And ultimately, the cohort of investors that you get are good people who champion for your cause. And it does get better when your business starts scaling, because ultimately that female-male co-founder thing just dies beneath the month-on-month growth or the business that you're getting in or the corporates that you have. So that conversation just loses limelight once your business starts growing.
I'm going to wait till Rahul Pathri tells us about his fundraise and fundraise challenges, and then give some inputs overall. So Rahul, over to you.
Sure, I echo with what Sylvana and Sara just mentioned about female co-founders. It was wonderful to listen to their stories. I do have female co-founders. Sometimes it can be a cliched thing. Sometimes it adds a lot of value. However, from an investment perspective, when we started our journey, uh, 10 out of 10 investors said you're working on, uh, it was not even a sophisticated question like you're working on a public health problem. You're working on a poor man's disease. How are you going to make money? Was the first question. 10 out of 10 investors asked since 2016. So luckily, I would say, India is very fortunate to have something in the form of BIRAC and the biotechnology ignition grants, which really facilitated and added the fuel to the fire, and we leveraged that. And thanks to COVID, now those questions are not asked. But and over a period of time, we did accumulate data in the non-communicable diseases, which is a big area of interest for most of the investors, be it COPD or asthma. We have gotten very close to even talk about a partnership with Cipla and Abbott, which took a different shape because they knew that we were focused on public health problems. But long story short, uh, investors even till now say that you're working on a public health problem, and how are you going to make money? Now we have business to government is our focus, so we definitely are going to make money. That thing is coming down, but it wasn't a bed of roses for the first 3 years. Things are shaping up now. We are looking at some brighter avenues dealing with investors as of today.
Thank you, Rahul. So I think I would like to end this session with a couple of points on in terms of investors and investment. Having been a female founder myself, having started Sonder Connect to support and empower female founders, I think all founders, whether male or female, do have challenges in terms of their initial fundraise, right? You need someone to believe you. That's why the whole concept of angels, funds, friends and family, start. Need that impetus where someone believes you. And typically, it's people who know you, whom you've worked with, or somebody from your family who's willing to support you. So I do not want to dilute the challenges as an entrepreneur. There are, every day I deal with a lot of male male founders who are having the challenges. Having said that, global statistics speak for themselves, which is less than 5% of all VC money is given to female founders. Here in India, I'm part of the founding committee for the CXXO, which was really a investment. One of the VCs here, Kalari Capital, created that. Bani Kola, who is the there to say how do we create a platform for women founders and investing in women founders. So it is definitely the statistics speak for themselves, but like in any other if you were to look at all the parameters put together, I think if you have a really strong team, you have a really strong idea, you have the grit to hang in there. I've raised money. I've not had the challenge of being said, hey, because you're a female founder, we're not funding you. So I think Sara and Sylvana, what you're doing is great. Rahul, I completely hear you in the fact that investors want to make money. They want to know whether is this social cause for which we're giving the are we giving grants towards it? But the good news is that the there are impact investors today. Okay, so I think that's the beauty. There are impact investors today who will want to make sure that they want to invest in companies like yours. So that's the good news. So look out for those impact investors who are not looking at immediate funds, but one of their investment criteria is to invest in companies like yourselves who are creating societal impact. So that's what my inputs would be. If we do we have any other questions? Let me look at the chat. I think we're good. Okay, great. So, Sara, Sylvana, Rahul, thank you so much for sharing. For all of the other founders who have joined us today, thank you for joining in. If you'd like to be a part of the founder series, please let Simran know, and happy to have you on our next series. Thank you, everyone, and congratulations to our founders here who are doing phenomenal work. Keep on doing it. You make all of us and life a better place for several millions of people. Good luck.
Thank you.
Thank you,
Thank you so
Latika.
much.
Thank
Thank you,
you.
everyone.
Thanks
Thank
for
you.
having us.
Bye.